Okay, thank you very much. Good afternoon to Sri Lanka. And my name is Kirana Arabage, one of the gynecologists, and also one of the gynecologists who's got a special interest in endometriosis and pelvic pain. So I've been, thank you very much to Dr. Matthews and the Sri Lanka College of General Practitioners to invite Sri Lanka Medical and Dental Association in UK to collaboratively deliver this lovely session for our colleagues in Sri Lanka. And so what I'm going to do is to talk to you about endometriosis, which is a very painful condition which affects quite a lot of women all over the world. And so how we can actually make a difference to their life in the primary care setting. So I would like to actually discuss how we're going to come to the diagnosis and start a management plan, which is very effective to patients. Sometimes you can manage them in the community without a referral to a gynecologist with a special interest in endometriosis in Sri Lanka. So these are the guidelines my talk is based on, and these are very recent and up-to-date guideline. And ESHRE guideline is a European Society of Human Reproductive and Embryology guideline on endometriosis, which was actually published last year. And the guideline committee was chaired by my colleague, Professor Christian Becker from Oxford, and also a nice guideline on endometriosis diagnosis and management. And there are several other, peer-reviewed articles, as well as my extensive experience has been included in this talk. So, I mean, globally, if you look at the endometriosis, it's affecting 1 in 10 women of reproductive age group. Anybody from teenage age group up until the menopause. But it is quite obvious now, quite a lot of menopausal women also experience endometriosis-related pelvic pain symptoms. So within the reproductive age group women, 3 out of 10 women experience fertility issues, 5 out of 10 women also experience chronic pelvic pain issues. This actually amount to 1.5 million women in the UK, and worldwide it is probably now 200 million. But this is a little bit old, cohort study. Based on these figures are based on the old cohort study. So if you can imagine the healthcare, the strain to the healthcare budget in UK, it's quite substantial, 8.2 billion out of 140 billion. These figures are also from the few years old figures, but this is actually based on the calculation done to lost working time and healthcare cost altogether. So what is endometriosis? Endometriosis is an inflammatory condition when the lining, when the lining of the womb, which is endometriosis, is outside the womb. So adenomyosis is considered as a endometriosis well within the wall of the womb, which is the muscle of the womb. So the word used as endometrioma when you have a cyst within the ovary. So how endometriosis causes its symptoms? And this endometrial-like tissue outside the cavity of the womb behaves like the same as they do in the cavity. So it causes acute inflammation and chronic inflammation. I mean, that's how it is. So the longevity of the disease is unknown, and so it takes sometimes too long for it to cause symptoms. Right. Main categories of symptoms are kind of 3 different categories. Pelvic pain symptoms are the most prominent ones, often cyclical, and heavy menstrual bleeding, HMB, could be related to adenomyosis. And the other group of patients are subfertility. They come with a combination of symptoms or one of symptoms with the pain or bleeding. And probably they have completed their family now. They don't have any subfertility issues. So each one need to be recognized. That is the most important. Recognition of the symptoms are the most important things. If you think about the symptomatology, if you don't put the whole thing together, you will never recognize that this is endometriosis. So it's very important to recognize these symptoms and also quantify the severity of the symptoms. So if you do not quantify the severity of the symptoms, it's like, okay, sometimes patients come to me and tell me, look, my mother says, when I used to have periods, I took a couple of paracetamol and went to school. What's your problem? And actually collapsed on the floor, which is really you're trying to make it up. That's not quite true, though. Actually, 99.9% of the patients who I see, their symptoms are very genuine, right? They don't make it up. They're not fake symptoms. I think it's very important to patient to know that you have recognized this and you have taken it very seriously, and you're not trying to fob things off. Right, that is a complaint that I get when I see endometriosis patient in my tertiary clinic, and listening to their story, and that is what has happened with some of the general practitioners, not all of them, of course, and some of the general gynecologists as well, which is sad. And I think if you do not get the whole picture, I know you have a limited time in the primary care setting, but it's important to recognize the cyclicity of the pelvic pain symptoms and cyclicity of the other symptoms, like I mentioned. So if you can ask, okay, tell me a bit about your period pain. Okay, is it heavy? Do you pass clots? Do you have any flooding? And if you are in pain, is it only related to that time of the period or just before? And if that is the case, tell me out of 10. 10 out of 10 is the worst pain, 0 out of 10 is no pain. So likewise. So then you need to talk to them about the bowel symptoms. Bowel symptoms could be pain at the time of the period, during bowel movement, and also some patients often have a cyclical, frequent, loose stool. This could be, and actually this is related to endometriosis within the pelvis. Some women actually think that is a completely normal symptom, but as far as it is not impacting their work, life, relationships, that's fine, anything. And also cyclical increased frequency of urination, often mistaken to a urinary tract infections. I have patients who have been treated for recurrent urinary tract infection, which is very which is not great at all. So I think it is important that we need to recognize this. So if a patient has pain outside their period or just before the period, and they have a good couple of weeks, that's great. But if they don't have it often, the reason for that is actually musculoskeletal strain of the pelvic floor. That is another cause. It's not endometriosis, but another cause which is associated with endometriosis, and they have long-term disease that needs to be separately recognized, because that cannot and will not be treated by medical and surgical treatment. Need pelvic floor help on the pelvic floor, physiotherapists, and pain during sexual intercourse, and extreme fatigue and kind of bloatedness is also not helpful. So, right, when patients come and talk to you about all of those things, how do you know whether this is normal or not? I think that is why objective assessment of pain scoring is important. You ask them not about anybody else. 10 out of 10 is you as an individual. The worst ever pain you felt is 10 out of 10. No pain is 0 out of 10. Where would you put your pain is what is important. And it is impacting life, work, relationships, and can't go to work, And also it affects mentally as well, because sometimes patients try to do lots of things and go on to this doctor, go on to that doctor, and now it's not really helpful. And probably this is in my mind, really, because then when they start thinking like that, this may be in my mind, and probably I'm not doing that. I'm really weak person. That's why XYZ do so well with their period, and I'm not, and I can't. And That's not the right way of thinking, and because that is actually showing some of the kind of depression and going into that rabbit hole. So I think it's important to recognize and empower them and tell them, look, this is not your fault, right? And so the accepting that this pain is real, and in front of the family members, this patient doesn't make it up, and it's not a fake pain, of course, and 99% of the time, believe it or not. And I've got loads of patients and all different ethnic groups, not only white British, and of course, majority of them are like that. But I think this is real. Acknowledging that and actually helps to accept it, and also other family members understand that. So, so pain is real, and there's a reason why you are in pain. It's not because you're weak. It's not because you're not doing very well, right? You have a disease. We need to look into it, right? How are we going to do? How are we going to diagnose? The clinical diagnosis is the most important thing, right? Taking a structured, systematic history is the paramount important thing that improve the engagement, that improve the trust of the patient with the clinician. I know you have very limited time in the community, but I think that time, if you spend wisely and also acknowledge stuff, and it'll do the job. So sometimes the examination is also relevant. If particularly they have a pain during sexual intercourse, you may be able to feel tender areas at the top of the vagina as well. So ultrasound scan is also important, but a negative ultrasound scan does not mean anything, but you still trust the patient. If the endometriosis scan or the pelvic ultrasound scan come back, I know you request a pelvic ultrasound scan from the radiologist, often it come back negative. Womb is fine, ovary is fine, no cyst and everything. But that should not alter your treatment and a referral process. It needs to meet, because I would really ignore the scan. I said, yes, scans are negative because scans are not really 100%. And I'll show you the figures of that. So what causes endometriosis? There are different theories, right? Retrograde menstruation is the most popular one. And when a patient has a period, and then period blood can actually drain via tubes. And a genetic basis is there. In our university here, and we do quite a lot of research into endometriosis and tissue sampling. We have biobank, and we look into different genomes, and which we didn't find yet a very significant collaboration. So embryological theory, immunological theory, and I think well, the combination of everything is actually make the endometriosis. So there is a delay in diagnosis. That is because the whole medical community do not recognize all these symptoms. It is very important to ascertain the cyclicity of the pain and other symptoms, and other systemic symptoms like bowel symptoms, urinary symptoms as well. And sometimes patients get referred to urologists because they have an increased urinary frequency and pain and unable to pee. But this happens only during period or just before the period. If you really carefully analyze it, you don't have to have a referral to urologist. I have patients came back to me after a urethral dilatation, which is quite expensive thing to happen. So, I mean, when a patient do that journey, right, they go to gastroenterologist sometimes. It's helpful, but they don't treat the cause. So it has to come to a gynecologist. Finally, if it is not responding, but otherwise you can manage it for years in the community. I would encourage and empower you to do that, and even in Sri Lanka. So delaying diagnosis is there because of various different reasons, because we don't have a proper diagnostic tool, but clinical diagnosis can be very effective, and 99% of the time it is actually you can make the diagnosis clinically. That's what I do, and I tell the patients as well without any scan. Okay, and so conventional ultrasound scan, actually, like I mentioned, and if it is negative, I wouldn't bother about it, and because as you can see, it's not 100%, 80% of the time it can recognize some of the lesions, but not all of the lesions. So these are the pelvic organs affected by endometriosis. As you can see, everything in the pelvis and bladder, bowel, ureters, kidney as well. And there are cases that actually can lead to silent kidney death, requiring a nephrectomy, removal of the kidney, because it is a silent killer if it blocks the ureter. So, but the patients, actually, if you listen to the patient stories, again, you can figure it out, and the scans can find out. These are some of the pictures, and if you can see at the top, that is the normal pelvis. You can see in the middle, uterus, and white bits are ovaries. If you can't remember your anatomy, and I won't blame, and the fallopian tubes on the side, and the bowel in the middle at the bottom around 6 o'clock position. But see what happens when you have a really bad endometriosis. It all gets, stuck. And loads of additions you can see, chocolate cysts you can see in the pelvis, and then some of the fibrous tissues, evidence of chronic inflammation, evidence of acute inflammation can be seen. This is a real problem. And 20 years ago, when I was actually in medical school, and those days even in here, and it is considered as an inoperable disease. There's nothing like that at all. Over the last decade, we can operate on any patients who do have significant disease, who are not responding to medical treatment. Okay, so I'll go into this. So these are actually some of the pictures. We can see chocolate cyst, as you can remember, probably from your previous experience, and some of the additions and as well. So often the disease is in the pelvis, and the worst disease is when it involves the rectovaginal septum. So on the right-hand corner, and you can see a sigmoidoscopy, and you can see a change of the bowel mucosa. The other one is actually laparoscopy, bowel stuck to the back of the uterus, and due to rectovaginal septal endometriosis. And this is a Cochrane study done, which I involved in. To find out, this is a little bit outdated now, about 10 years ago, but still the laparoscopy is the gold standard for diagnosis, but that is the diagnosis of laparoscopic diagnosis. Clinical diagnosis is completely different, and you can rely on the clinical diagnosis, and you can back that up if you as far as you take a systematic history, and that's what I do. And there is a poor correlation between disease severity diagnosed at laparoscopy and symptoms, because the volume of the disease doesn't correlate with severity. If you think there's a large cyst and the symptoms should be really bad, it doesn't work like that. And it's really bizarre, and therefore the volume of the disease doesn't correlate with severity of the symptoms. So if I go back to quickly show you, what sort of surgery we do, and you can see here that is a endometriosis. This bit of the peritoneum is completely normal, and this is a tube on the left side of the pelvic side wall, the tube, and you can see the ovary here, and we are trying to mobilize the ureter. You will see it soon now here, and as you can see here, that's the ureter, and this is a plaque of endometriosis. You can clearly see what is normal peritoneum, what is abnormal peritoneum. This is what it does to the pelvis. And also you can see the bowel going on from here. And there are quite a few nerves here, like hypogastric nerves, which control the bladder, bowel, and sexual function. And they can be affected. See, that is the hypogastric nerve. The peritoneal reflection is the hypogastric nerve, which I'm demonstrating here. So it's very close to these the vessels. So if I go back to the next slide, and so this is actually the final excision of the pelvic endometriosis done. The bowel is here, uterus is there, over here, and this is the ureter, and the nerves have been all preserved and disease have been removed. These patients do very well when the primary treatment is not really doing very well. So there's a BMJ article. This is a landmark paper, which is probably first in the world, which we published based on the endometriosis center experience in the UK, based on 5,000 patients to find out when we do laparoscopic surgery by a trained, accredited endometriosis surgeon, what is the treatment efficacy? So treatment efficacy is actually really good, and 5 out of 10. Like say for example, if a patient come and tell you my period pain is 8 out of 10, and the chance of it going down to 3 out of 10 is very, very high. So the treatment efficacy is 5 to 6 out of 10, right? And also, if you think about the complications, people think, okay, all right, there's a huge number of patients have really life-changing complication, which is not true. There are complications happen, and that is about 1 out of 100. I'm sure it is the case in Sri Lanka in some of the main centers. I do have no idea about the other things. I have involved in actually training consultant over the years, consultants who are interested in endometriosis surgery, and I managed to set up one in Lanka South Hospital as well in the past with the colleagues there. So, like again, I have to tell you, severity of the symptoms do not correlate with the volume of the disease inside. So there are myths about endometriosis. Menstrual pain is in your head, which is not really the case at all. And there are lots of non-specific symptoms like bloatedness, but that is actually correlate with the endometriosis if all the other cyclical symptoms are there. But I think this is very important. It's a carrier women's disease. It's all myths, and pregnancy and hysterectomy cures endometriosis symptoms. It is not unless you excise it surgically. So what are the initial treatment modalities that you can do in your community? I think, sorry, I need to explain everything to you before I come to this one. So I think I have, before give this talk, I've done quite a lot of search in Sri Lanka current practice with some of the senior colleagues in the university as well as outside. So I wanted to give you the kind of the best knowledge how we can do it. There shouldn't be any, like, if the patient is not planning to fall pregnant, of course, hormonal treatment is beneficial. So in the form of combined oral contraceptive pills, it is indicated, it is recommended to start them on oral contraceptive pills. But the problem is often they are 21 days and 7 days break when they have a bleed and they can have pain. That pain can be managed by using mefenamic acid, ibuprofen, paracetamol. There is another way of doing that. You can actually do tricycling. Like you can use 3 pill packets of 21 days together, and then the patient can have a period after 3 months. That is called tricycling of the combined oral contraceptive pill, which is actually recommended established way of treating patients. So it's very, you need to very carefully manage the side effects as well. Of course, you need to look into the indications, contraindications of each pill. And then if one pill is not working after 2-3 months, you can change it to another pill, right? This is very effective for especially the teenage schoolgirls and university, patients in higher education, at work, not planning to have children for the next few years. So progesterone only pill, I understand it is it's non-existent literally currently, and there is something called noriphysterone primalute in Sri Lanka, which I also familiar 20 years ago. And primalute is actually not probably a good medication to use for months and years. But probably you can use it for about a month without a problem, or 2 months, and it may not be a great one for over the years, over the months to use. But yes, Depo-Provera can be a good one, but there are side effects like putting on weight. And if you use it for more than 2 years, you need to check the bone health. Or you can actually, because it can really affect the bone and cause osteoporosis. The Mirena intrauterine device or other progesterone impregnated hormonal device can be inserted into uterine cavity. It's like a coil and it's very effective. 9 out of 10 women are very happy with it. It gives the patient lighter period, less painful period, treats endometriosis, adenomyosis without a hysterectomy, and also it prevents the progression of the pain symptoms. And it is a fantastic contraception. With a efficacy of efficacy equivalent to sterilization, and with a failure rate of 1 in 200. Of course, GnRH analogs can be used probably when they completed their families, and probably preferable towards the end of their 40s when they're going through the menopause, just to avoid the operation. It can be used for up to 6 months initially, and then with a review, it can be used even more than that. Gynecologists have started coming back to the market as well in Europe, and I think this is the medication was available in Sri Lanka. So the analgesics, I'm pretty sure you are quite familiar with. Tranexamic and mefenamic acid is available in Sri Lanka. You can use it for if the patients have period-related symptoms only, like heavy, painful periods, and it's very effective. Tranexamic acid 1 gram, 2 tablets at a time, 3 times a day for 5 days, and mefenamic acid 500 milligrams 3 times a day for 5 days, with or without gastric cover. So that's very helpful. But if the patient doesn't have other symptoms throughout the cycle, you can why patient want a hormonal treatment? You can actually give tranexamic mefenamic acid. They'll be absolutely happy. The two together work synergistically to minimize the blood loss and the pain. And if a patient has a neuropathic component to the overall pain, how do you find out whether there's a neuropathic component? If you ask the right questions, like whether you have a sharp shooting, stabbing pain or a burning pain, and those are the signs of extrasensitization of the nerves. If the patients have that sort of symptoms, which is actually very short-lived, like few seconds or minute, and actually you can prescribe something like amitriptyline, very small dose, 10 milligrams, but to be taken around 6 o'clock in the morning, because otherwise if they take it late in the night, it gives them a groggy feeling, really dizzy, nauseous feeling following the morning. But to avoid that around 5, 6 o'clock, it's a very good medication to start with that will actually minimize the intensity as well as severity of the frequency of those sharp stabbing, shooting type of pain. So you can actually put them on tranexamic, mefenamic, and amitriptyline daily basis for about 3 to 6 months also to start with, and take it from there. So if you recognize if the patient has a non-cyclical component to the pain, which get worse with the physical activity, I would strongly recommend you to send them for a pelvic pain physiotherapist, because that cannot and will not be treated by any of these things, right? It's not in their head that is really serious. And those muscles it's not a weakness of muscle. The muscles are not weak, and actually the tone has got tone is actually different because they tend to sit down differently. They tend to walk differently when they are in quite a lot of pain due to endometriosis to start with. And with time, they have this problem of, musculoskeletal strain of the pelvic floor, which can only be diagnosed and treated effectively by pelvic pain specialist physiotherapists. And so there are 3 different types of pain, causes of pain I have talked to you about: endometriosis, neuropathic pain, and also pain related to MSK. But all these causes of pain is actually probably originated by the endometriosis in the pain. But then when you have to manage, you have to really ask the right questions, and you can find out what exactly causing, and you can tailor your treatment to that to affect the patient. So just a couple of minutes if you are interested in endometriosis is not only in the pelvis, right? And about 10% of those 1.5 million population with endometriosis in the UK has endometriosis elsewhere in the body. So we've done a large survey in the UK, which I involved in as the Secretary of the British Society, ex-Secretary of the British Society for Gynae Endoscopy. We have actually looked into different, organs, the knowledge about the disease among the gynecologists who are treating it. It's very poor, right? And so some patients do have a cyclical pain in the right upper quadrant, cyclical pain in the shoulder tip pain, which could be a sign of a thoracic endometriosis. It's like a cancer, but it's not a cancer, and it behaves like a cancer because it's and I mean, it's in the central nervous system, peripheral nerve, lymphatics, and close to surgical scars. Some women have endometriosis on the cesarean section scar, umbilicus. But the golden question you need to ask is, I mean, these are the parts of the body you can find it. Even on the episiotomy scar, the patient may come with pain. Actually, doctor, I have a pain down below, but it only happens during period. But the pain is actually in the perineum. I do have pain in pelvis, but I have significant pain in the perineum. But if you don't ask, if you ask the right questions, like whether you have a episiotomy scar, and if you examine, when you touch it, and around that time it's really tender, and also inflamed around that area. So it's important to the message is actually the cyclicity of these symptoms is the first thing. Some patients come to you to say, doctor, I'm in pain every day. But then the next golden question you wanted to ask you is, when you start everything, did the pain only related to the periods, around the time of the periods? And so that will give you the guidance. This is most likely endometriosis related symptoms. And so, I mean, if you find an endometrioma in the ovaries, or other significant endometriosis involving bladder, bowel, on the scan. But remember, ultrasound scan done by the radiologist will not comment on the bladder disease if there is obvious bladder nodule, right? If there's obvious cyclical bleeding, hematuria. If there's often they have the disease on the bowel or the bladder, but actually it is actually not detected by the radiologist because it needs kind of specialist knowledge to do those ultrasound scan. Otherwise, the detection rate is very poor. And so MRI scan can help up to some extent. And but if the patient is not managing very well their symptoms, I think it's a really good idea to refer them to a gynecologist who is a specialist in endometriosis as well. And I think they can help. And I think in the country, in Sri Lanka, there are only a handful of people who actually, to my understanding, do a really good job for the patient surgically. And I have a lot of other respect for all the other gynecologists because they are really good at doing different things because they have a different specialties. Now in the UK also, I mean, and the gynecologists have branched out and specialized in different areas, and so because they can't really focus on everything. But I'm sure in Sri Lanka, that's what my knowledge is as well. We work with the College of Gynae in Sri Lanka to improve the skills and the knowledge, and happy to share the knowledge and work together with them to improve the quality of care. And thank you ever so much to Dr. Matthews and the council to inviting SLMDA and me to give this talk. And my special gratitude goes to Professor Antoinette Pereira and Professor Leela Karunaratne, who actually train us and teach us with a lot of passion to look after patients, and so which has been always helpful. Thank you.
Thank you very much for that very insightful lecture, Dr. Kirana. We have a question on the chat box, and due to the interest of time, we will entertain maybe one on-site question. There are any?
Sorry, I can't see the question. Oh, it's in the chat, right? Okay. So I can.
We have a question on site as
well. Can you please read the question for me? Is this the question? Primary care. So can you kindly please read the question to me?
The dose of duloxetine for neuropathic pain usage in the endometriosis.
Yes, it can be used. It's very helpful. And thank you for that question. It's very, very valid question. Duloxetine can be used for, I know it's used quite a lot for the patients who have bladder symptoms, but it is being used for the patients who have neuropathic pain. And I think probably first line could be amitriptyline. And if it is not responding, you can actually trial duloxetine. But I think it's important to try and find out whether that patient has a significant neuropathic component to pain. I think the medical treatment for endometriosis is always based on hormones. And so that is actually probably the first line. But if the patients symptoms are only related to the periods, you can actually do tranexamic mefenamic acid. But if they have pain in between, like sharp shooting, stabbing type of pain, and of course, you can put them on amitriptyline and other neuropathic pain relief.